Okay, so the topic today is hyponatremia, and I'll start with the case. I can advance my slides. Okay. Oops. Okay, so the first case is a 31-year-old woman with no significant past medical history who was brought to the emergency room after a witnessed seizure. So on exam, her temperature is 99.1, blood pressure 90/42, heart rate was 100, respiratory rate 22, oxygen saturation was 100% on room air. Her weight is 60 kilograms. On exam, she had moist mucous membranes, her lungs were clear, heart sounds were normal. Her belly showed multiple well-healed surgical scars. It was soft, there was bowel sounds were present, and she had no edema. And these are her labs. Sodium of 105, potassium of 3.8, chloride 80, bicarb of 20, BUN 3, creatinine 0.3, glucose is 72, calcium 8.2, and phosphorus of 2.5. So my question to everybody is, what will happen to her serum sodium if we give her a liter of normal saline? Can anybody start?
So feel free to unmute yourselves to answer these questions. I see, Fatma, you posted in the chat if you want to unmute yourself.
So my thinking, preliminary, also we don't have the urine studies yet, but I think that it is syndrome of inappropriate antidiuretic hormone might be the underlying cause, giving her recent seizures. So I think if I give her more fluid, it's gonna worsen her.
Okay, so you made a very good point. You said that we need to see what her urine studies were, right? But I'm going to show you a formula that a lot of people tell me about.
I would say urine studies and urine osmolarity and serum osmolarity as well.
Okay, very good. This formula, as you can see on the screen, was published in the New England Journal of Medicine in the year 2000 by two giants in the field of nephrology, Dr. Androgi and Dr. Madias. And they said that in this formula, you can predict the change in serum sodium by seeing what your infusate sodium and your infusate potassium is, minus the patient's serum sodium divided by the patient's total body water plus 1. So if we use this formula in this case, we are giving normal saline. So the infusate sodium is 154. There's no potassium in our normal saline, so there's nothing. Minus the serum sodium of the patient, which is 105, divided by her total body water, we said she was 60 kilograms. So just half it for convenience sake, we'll say her total body water is 30 kilos plus 1 because we gave a liter of normal saline. And if you plug in all the numbers, this formula will tell you that giving her a liter of normal saline will cause an increase in her serum sodium by 1.58 milliequivalents per liter. Now, Fatma, what do you think is wrong with this formula? Can we say it's wrong? It was published in the New England Journal of Medicine in the year 2000.
I mean, it's not accounting for how your body regulates.
Yeah.
Minerals.
Excellent, excellent.
Yeah.
So this formula assumes that your body is a box. So we're just pouring in a liter of normal saline, stirring it around, and then seeing what the resulting serum sodium is. And as Fatma already raised earlier, is that the most important organ, the kidneys, we're not taking into account how the kidneys are going to manipulate this liter of normal saline that we're going to give the patient. So if you have an end-stage renal patient who's anuric on dialysis, and they come in with a sodium 105, then this formula can work, given if they don't have severe diarrhea or any, significant losses. So an end-stage renal patient who's anuric, this formula will work. But everybody else, this formula ignores what the kidneys are going to do to that liter of normal saline. So I'm going to give you a little bit more information. Let's say these are her urine studies. So her urine osmolality is 620 milliosms per kg. Her urine sodium is 220 millimoles per liter, and her urine potassium is 90 millimoles per liter. What do you think of these urine studies? What do they tell you? What do these numbers tell you? Is ADH present?
Yeah,
ADH is present. Why do you say ADH is present?
because the urine is concentrated and we have excretion of the sodium. So in a way, our body is holding back the water, but not the salt, which, what ADH does.
Okay, so the urine osmolality is 620, which is much higher than the serum osm. So you know the ADH is present. And you see that these kidneys are excreting urine sodium at 220 millimoles per liter and urine potassium at 90 millimoles per liter. These kidneys are not holding on to sodium, right? So that means that this person is not hypovolemic unless they have something wrong with their kidney tubules. So these urine studies go with what Fatma had surmised earlier, saying that this is probably ADH coming from somewhere, not triggered by osmolality because the patient is already hypoosmolar, and not triggered by volume because these kidneys are not holding on to sodium. Okay, so now you have the numbers. Urine osmolality 620, urine sodium 220, urine potassium 90. My question to you is, if you give this person the liter of normal saline, what will her serum sodium be after that liter of normal saline? If you can give me a specific number.
So she's losing.
Anyone?
How would you even go about answering my question given these numbers?
I'm not aware of any formula, but since the patient seems to be holding on to fluids and losing sodium, the sodium is expected to be lower than 105, but I'm not sure exactly how much.
Okay, so you all, it's absolutely true. So I'm going to show you how we can go about answering my question. In the urine, in the serum, we often ignore potassium, right? Just because serum sodium is so much higher than serum potassium. But you always have to keep in mind that potassium is just as osmotically active as sodium. And in the urine, as you see in this case, even though the urine potassium is still smaller than urine sodium, it's not that insignificant. And oftentimes in urine, sometimes we can have urine potassium that's even higher than urine sodium. So always think of potassium as sodium when you're dealing with hyponatremia cases. So we're going to count potassium just like we count sodium. So we just said a liter of normal saline has 154 millimoles of sodium. The urine has 220 millimoles of sodium plus 90 millimoles of potassium. So we add them together, that's 310 millimoles per liter, because we say we consider potassium just like sodium. So in that liter, meaning that these kidneys do not need salt, right? We just said that, the patient has no signs of hypovolemia, so the kidneys will not hold on to any salt. So if you gave these kidneys 154 millimoles of sodium, the body doesn't need any of the sodium. All the sodium will be excreted in the urine. And since these kidneys are peeing out a urine that has 310 millimoles of sodium in it, it means if you give them a liter it will pee out that 154 and half a liter of urine. 310 divided by 154 divided by 310, that's half a liter. But you gave a liter, so that means the kidneys retain half a liter of free water in the system. And therefore, as Joseph and Fatima said, the serum sodium will go down. Now, we did not change the total sodium content of the body, right? We said we gave 154, but all of it came out in the urine. So the original sodium content we have is 105 times the patient's total body water, right? That was her starting serum sodium, 105 times 30, and this gives us her total sodium content was 3,150. We did not change 3,150. We did not add any sodium. We just added half a liter free water. So to get the final sodium concentration, it'll be 3,150 divided by 30.5, and that will give you a serum sodium concentration of 103.
Can I ask a question?
Go ahead.
Are we assuming that sodium potassium excretion in the urine stays the same?
In this case, yes.
Change?
In this case, yes, but you're absolutely correct. Things can change. Things can change, and especially in people coming out with inappropriate ADH, the stimulus for the ADH can get shut off. For example, if the inappropriate ADH or the inappropriate ADH effect was coming from a medication, and once the medication effect is gone, all of a sudden ADH is shut off, these kidneys will start putting out a very dilute urine. Or the stimulus may be nausea. We see this a lot in post-op patients or post-chemo patients. And all of a sudden you treat their nausea, they're not nauseous anymore, ADH shuts off, they may be putting out a very, very dilute urine. But in this situation, we're just going to say we have to start somewhere, right? So given these kidneys putting out this type of urine, if we gave her a liter of normal saline, her sodium's going to come down from 105 to 103. Any questions? Okay, what about the kidneys show these kind of urine studies? Urine osmolality of 50, urine sodium of 10, and urine potassium of 10. What's going to happen when you give a liter of normal saline? Now you guys do the calculations for me.
Oh.
From these numbers, do you think ADH is present?
No,
Why not?
the urine is hypoosmolar. It's 50 urine osmolarity. So this
The
means
urine osm is 50. You're absolutely correct. This is the most dilute human beings can make our urine. This is a maximally dilute urine. So there is no ADH. Do you think these kidneys are holding on to salt?
Yes.
yeah,
Why? Why yes?
because the urine sodium is very low.
The urine sodium is very low, but these kidneys are not holding on to salt. The urine sodium concentration is very low because it is a very, very dilute urine. So the concentration of anything in this urine is going to be very low. If you do a urine creatinine, if you look at a urine creatinine in this urine, that creatinine number is going to be very low. So everything is low. So don't just look at urine sodium and say, oh, 10 millimoles per liter. It's a very the kidneys are holding on to salt. No, this is just the urine sodium concentration is very low because the urine is so dilute. If this were a urine of somebody who's hypovolemic, hypoperfusing their kidneys, the urine sodium would be very low, but the urine osm would be very high, right?
Mhm.
A person who is hypovolemic would be putting out a very concentrated urine with low urine sodium. That's not the case here. The person is putting out a very dilute urine, and therefore everything in this urine is going to be low. So if you give these kidneys a liter of normal saline, what will her serum sodium be?
I think Subrat has managed to do the calculation.
All right. I can't see them though.
Are you able to unmute yourself, Subrat?
Hi, Ruchen. Yeah, so
Oh,
I went through the calculation. I think the patient is going to lose like around 7 liters of fluid.
yes,
So
excellent.
that brings out the sodium to 136, given that we are at equilibrium.
So you're absolutely correct. If you give these kidneys 154 millimoles of sodium and they're peeing out 20 millimoles per liter of sodium plus potassium, these kidneys will dump out that 154 in 7.7 liters of urine. And because we gave 1 liter, that means that she will be net out 6.7 liters. So if you divide back 3,150 divided by 30 minus 6.7, you will get a sodium of 135. So in this situation, you gave a liter of normal saline and you corrected this woman from 105 to 135. And you gave the nephrology attending a heart attack because it went up by 20 milliequivalents, way, 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 way too fast, right? So it's very important. We just did the same intervention, 1 liter of normal saline, but depending on what the patient's kidneys are doing, we can end up decreasing the sodium by 2 milliequivalents more, or we can end up increasing the serum sodium by 20 milliequivalents too quickly. So always be very careful. And as one of you also pointed out, it may not be static. The kidneys may do different things at different times, depending on what the situation is and what the stimuli are. So the key is you always have to follow.
Dr. Chan, yeah. I have a question regarding, we're using now more and more than normal saline lactated ringers. We're using LR. It's the only thing that you just, like the same thing you would use the same formula to correct for that. You just add the potassium and the sodium content, or no?
Correct, correct.
Okay.
Correct. You know, LR is, in terms of sodium, I mean, it's a little bit lower than normal saline, but it has 4 milliequivalents of potassium. In general, it's slightly a little bit hypotonic to normal saline, but you know, given these kind of situations, you do the same thing. But the key is you have to follow, because as somebody else already pointed out, the kind of urine that the kidneys are going to make, it can change depending on, you know, the presence or absence of ADH. So oftentimes we can have a patient coming into the emergency room. They may start out with the first set of urine lights showing that they're putting out a very concentrated urine because ADH is around. But then after some intervention, ADH may be shut off. And all of a sudden, they're pouring out very dilute urine. I mean, that is one of the reasons why we often ask for a Foley in patients with severe hyponatremia, because that's how we can really follow the urine output closely. And it's very frustrating when we don't know, like, because all of a sudden, if you see the Foley bag filling up, you know, very quickly and it's about to burst, you know, somebody is putting out an extremely dilute urine and you're going to run into trouble by rapidly overcorrecting. Any questions? Okay. So let's do another case. So it's a 73-year-old woman with dementia who was referred to the emergency room from the nursing home for pneumonia. So in addition to antibiotics, she was also getting high protein supplement. And this solution contains about 30 milliequivalents each of sodium and potassium. And that was started because we were trying to improve her nutritional status. So at admission, the patient had no electrolyte abnormalities. 5 days later, she was noted to have 4 liters of urine per day. And these are her labs. Her urine sodium is 156, potassium is 4.6, chloride is 113, bicarb 26, BUN 35, creatinine of 1.2, glucose of 110. And these are her urine studies. Urine osm is 505, urine sodium is 12, and urine potassium is 42. So here's just an example where you can see the urine K is actually higher than the urine sodium. So we can never ignore potassium in the urine. So the question is, why is this patient polyuric? And what kind of diuresis does the patient have? Water diuresis, solute diuresis, or a combination of water and solute diuresis? So I'm going to go back to the previous slide so you can see the numbers. So first of all, how do we define whether somebody has polyuria or not? What does the textbook say?
I think it's like the volume of urine per day or per kilogram per hour. In this case, more than 2 liters, I remember. I'm not sure. Per
I
day.
think the textbooks usually say it's 3
1 to
liters
2.
of more of urine per day. Yeah, but that's like a totally random artificial number. To me, I often want to think like, is this amount appropriate or not appropriate? Like, I mean, if you go out and you drink a keg of beer and have 2 pizzas, then you're going to pee a lot. But if you're drinking nothing and you're still peeing 2 liters, even though 2 liters is under 3 liters, then there's something wrong. So that 3 liter number is very random and totally artificial. So, but in this case, we have a problem, right? Because she's putting out 4 liters of urine and she's hyponatremic. So the question is, what's going on here? Does she have a solute diuresis, a water diuresis, meaning some form of DI, or a combination of the two? And how do you go about sorting this out?
Is it based on the urine osm, where if it's less than 300, it's 1, if it's more than 600, it's 1, and then if it's between the two, it's usually a combination?
We do look at urine osms, and we go more by, how many milliosms the patient is putting out in a 24-hour period, because that's where our standards come from. Average osmolar intake in this country, and I guess in most parts of the world, is about 600 to 900 milliosms per day. So if we put out more than, if our urine osm output is more than 1,000 milliosms per day, we will define it as a solute diuresis. So in this case, what is her urine osm output?
So it's 500 times 4, which is 2,000.
Yes,
So
2,000. So it's sky high. So this is a solute diuresis. Now we want to know, is all the water that's coming out obligated by the solute diuresis, or there's an additional component of water coming out as water? And that would be inappropriate in this case, given that she's hyponatremic, right? So the question is, now we know she definitely has a solute diuresis, but does she have a component of also water coming out, just as water, and not being dragged out by any solute?
Given that her serum sodium is high, so this goes more with water diuresis?
We already established that she has a solute diuresis because we said her total output is very high, right? 2,000.
Yeah.
So now you want to look at the urine. So compared to the plasma, is the urine more concentrated or not? What's her plasma?
Yes, it is.
Yes, right?
Yeah.
What's her plasma osm? Her plasma osmolality, if you do how do you do it? 2 times sodium plus glucose divided by 18 plus urea nitrogen divided by 2.8, right? And the plasma osm, when I did the calculations, was 330. So that means the urine osm is higher than the plasma osm. And when we do a water clearance, this is the formula. The volume of urine times 1 minus urine osm divided by plasma osm. And since urine osm is higher than plasma osm, that fraction is greater than 1, correct? So there's no water excretion. There should be water reabsorption. So this doesn't make sense, right? If the urine osm is more concentrated than plasma osm, and we try to see how much water is being excreted, this formula actually tells us there's no water excretion. If anything, there's water reabsorption to the tune of 2.1 liters per day. So if that were true, what's going on? How come the patient is becoming hypernatremic in front of our eyes? And that's because when we look at hyponatremia, we're not looking at total osms. We're looking at more the relationship between water and electrolytes. So it depends on what are these urine osms. Are they mostly electrolytes or are they something else? And in her case, we already said
there's something else.
There's something else, right? Because the urine sodium was only 12 and the urine potassium was only 42. You add those two together, 64 times 2 for the anion part, that's still only 120 something milliosms, right? Cations plus anions, only 120 something. So most of those urine osms are something else. What's your guess?
The
Proteins or
nutritional.
lipids?
Yeah.
Sorry, couldn't hear you.
For me, proteins or lipids?
Exactly, protein that gets broken down into urea. So urea is most of those urine osms, and urea in the urine pulls out water. So now we go back and we don't look at just total urine osm, because here we're interested in hypernatremia, right? So we're interested in water, in relation to electrolytes. So instead of using total urine osm, we use urine sodium plus potassium divided by plasma sodium. Both numerator and denominator would be times 2 to take care of the anion, but since times 2 on top and times 2 on bottom, we can just cancel it out. So you can just look at urine sodium plus potassium divided by plasma sodium. And here it's 1 minus 0.4. So we know that the electrolyte free water clearance per day is 2.4 liters. And this water is not coming out as water by itself. So it's not a question of DI. This water is being pulled out by urea. That is a metabolite from the high protein supplement. So therefore, these kidneys are putting out a solute diuresis. And most of that solute is urea from protein degradation. And therefore, the patient is losing electrolyte-free water in the urine and becoming hypernatremic. So how would you correct her hypernatremia? I'll go back to show you that. What's that?
Probably stop those nutritional supplements that are high in supplemental protein.
We can do that, but she needs it. Maybe we should just give her back more water.
So we can probably add some more free water to compensate for the deficit of the electrolyte free water deficit.
So tell me your calculations. How much are you going to give to her?
To just compensate, it's going to be 2.4 liters to keep it at balance, which is the water.
So what's her free water deficit?
Okay, I have to calculate that.
So let's say she's 60 kilos again. So her sodium is 156. She's 60 kilos. And we say that every day she's losing 2.4 liters of electrolyte-free water in her urine.
So we add that to the 140, we add that to the sodium water correction part of it. Like whatever the number comes out from 156 minus 140 for, let's say, for the normal value of sodium, plus the 2.4 liter for that day.
Excellent. So free water deficit, you guys all have the formulas on your phones. 156 over 1 over 140 minus 1 times the total body water. So her free water deficit is 3.42 liters. But just giving that back, that 3.42 liters is not going to do enough because, as we said, she keeps losing 2.4 liters per day. So you need to give that, the deficit, plus the ongoing losses back to her in order to correct her sodium. And if she's having fever, you may need to add back more for insensible losses. If she's having diarrhea, you will need to add more for that. So the key is just come up with something, try it. And if the sodium is not correcting as you want, give more. If it's going too fast, give less. And in general, we're less jumpy about correcting hypernatremia too quickly than hyponatremia. The experts seem to say that we can correct hypernatremia more quickly than hyponatremia.
Would you give free water or would you give like half normal saline or anything like that?
Either one. If you give half normal saline, you would have to give double the volume to give the same amount of free water, right? And this is another point. If you give normal saline, how much free water are you giving?
Not any?
Not any. Excellent. If you give half normal saline,
Half a liter.
half of that is free water. If you give half normal saline plus 40 milliequivalents of KCl per liter.
None?
Saying again.
If you give half normal saline plus 40 milliequivalents of potassium chloride per liter, how much free water are you giving?
We're back to zero almost.
Okay, 0. Yeah.
Almost
70
like
plus 40,
250.
gonna be like 110 compared
I
to
think-
140, so 400 ml.
Yeah.
Well, your normal saline is not 140, right? Your normal saline is
154.
154.
It's
So
we're giving
110 divided
75
by
plus 40.
154. So it's like a quarter free water. So my point is, if you add potassium chloride to your fluid, you're gonna decrease the amount of free water you're giving. How much free water are you giving if you give D5 half NS?
Around 500 cc per liter.
Yes, so it's same as half normal saline because D5 is metabolized, right? D5 only causes trouble, or any kind of glucose solution only causes trouble if your patient develops hyperglycemia. And if they develop hyperglycemia and subsequent glucosuria, then the glucose in the urine is going to make them lose more electrolyte-free water in their urine. Just like urea, glucose will pull free water with it in the urine. So if you give somebody D5 and their finger stick or their blood glucose is persistently 280, 300, you're going to make the hypernatremia worse because they're losing it in their urine. I have another case, but it's going to take a while. And I only have 10 more minutes, right?
Yeah, that's okay. You can go ahead with it. That would be great.
I have a quick question about this case.
Sure.
So, like, what would you recommend for the primary team in practicality for like the actual order, like the rate?
Okay, so we calculated her free water deficit is 3.42 liters. And let's say you want to divide it up to give that over 2 days. And every day she's losing 2.4 liters. So in each day, she will need to get at least 4 liters of free water. Now, for this person to have developed hypernatremia to the degree of 156, we already know that she's not somebody who can drink adequately for herself. She's probably elderly, demented, or she can't get to water, nobody's helping her or something, right? Because even if you have central DI, And even if you are peeing 10 liters of urine a day because you have central DI, you will be able to protect yourself by drinking, because you're going to feel thirsty and you're going to drink and you're going to keep drinking, and your sodium may be 146, 147, but it will never be 156. So this person already proved to you that she cannot drink adequately for herself. So you're going to have to give it to her. You can give it to her in two forms, IV or by mouth or through NG tube or OG tube, right? So you can half it. So you can give 2 liters of free water through the IV, 2 liters through the NG tube. Or you can give it all by IV. So it kind of depends on the person. So if it's 4 liters of free water a day divided by, so that's going to be at least 170 cc's of D5W per hour. And if the patient's diabetic, that may be a problem if the glucose control isn't tight enough. So you can give 2 liters by IV, 2 liters of D5W per day. So that's like 80 to 85 cc's of D5W per day. And then you can give 2 liters by mouth or through NG tube. So it's like 500 cc's Q6 hours by NG tube. Or you can have an attendant stare at her and have her drink 500 cc's every 6 hours, just like a medicine.
Is there a reason we can only give D5 water in IV, or is that not a thing?
As opposed to what? Sterile water?
Yeah.
Sterile water, you can never give IV because it's too hypoosmolar and your red cells will lyse.
Got it.
So D5W is isoosmolar, but because we can metabolize the glucose, it becomes just water.
Got it. Thanks.
So in some cases, in some pediatric hospitals, they don't even give half NS because they are worried of red cell lysis. So probably in terms of osmolality, half NS, or, you know, that is the lowest that the pharmacy will agree to go to. Okay, so we'll try. So before I move on, I just want to impress upon you guys that potassium is just as osmotically active as sodium, and we tend to think of the two as one. So, and this is the reason why. So remember the formula for plasma osmolality is 2 times sodium just to take care of the anion and the cation part. And we can ignore in this formula potassium because plasma potassium is so much lower than serum sodium. Plus glucose divided by 18, and 18 is just the fudge factor to change glucose from milligrams per deciliter to millimoles per liter, plus BUN divided by 2.8. Once again, that's the fudge factor. But if we're talking about effective osmolality, so things that affect water movement, we don't worry about urine nitrogen in the blood because urine nitrogen, given enough time, will equilibrate inside and outside of cells, right? So it's an ineffective osmol. Now, this is different from urine nitrogen in the urine. We just had an example of the old lady developing hyponatremia because urea nitrogen in the urine pulls water with it. And that's because in the kidney, not all parts of the kidneys are, urea nitrogen can't go in and cross the cell in the kidney. Some cell membranes are impenetrable. And also there's not enough time as urine traverses through the kidneys for urea nitrogen to equilibrate. So urea nitrogen is an ineffective osmol in our system, in our plasma, but an effective osmol in urine and can pull water with it in the urine. So if you have somebody who has normal serum glucose, and the contribution of glucose divided by 18 is also much, much smaller. So we can also ignore it if you have normal glucose levels. So in essence, effective plasma osm is equal to 2 times serum sodium. Now in our system, we are in osmotic equilibrium inside and outside of cells. So the effective plasma osm equals the effective osmolality of our total body water, meaning extracellular solute plus intracellular solute divided by total body water equals the effective plasma osm. And as you know, sodium is the main exchangeable cation in the extracellular space, and potassium is the main exchangeable cation in the intracellular space. So effective plasma osm equals 2 times exchangeable sodium plus 2 times exchangeable potassium divided by total body water. You get out the 2. So serum sodium is equal to exchangeable sodium plus exchangeable potassium divided by total body water. So all this mumbo jumbo is just to try to impress upon you that potassium is just as osmotically active as sodium. And that's going to have a bearing on our next case. There's a 59-year-old woman with hypertension who came to the emergency room complaining of worsening weakness for 5 days. For 2 days, she was unable to ambulate. And on the day of presentation, she couldn't get out of bed. Her review systems, she has nausea, no vomiting. She has paresthesia of her hands and feet, denied shortness of breath, no chest pain, no cough, no diarrhea, no rash, no headache, no dysuria, no visual change, no past surgical history. Her medications include combination pill of losartan and hydrochlorothiazide, Aleve, Zocor, and Clarinex. She's a paralegal assistant. She's married. She drinks 1 glass of wine with dinner. No cigarette smoking. No illicit drugs. On exam, blood pressure lying down, 143/67, heart rate 60, upright, blood pressure 120/50, heart rate 120. She was afebrile, respiratory rate 16, 99% sat on room air. Her weight is 65 kilograms. She had dry mucous membranes, lungs clear, heart sounds normal, abdominal exam unremarkable, no edema. She was alert and oriented, but she was weak. And these are her labs. Sodium of 96, potassium 1.6, chloride less than 60, bicarb of 38, B1 11, creatinine 0.5, glucose of 86, calcium 8.4, magnesium 1.9, phos 1.8, serum osm is 201, and EKG showed QT prolongation. So over the next 24 hours, she drank 400 cc's of water. She had IV intake of about 800 cc's. Everybody was very upset about her QT prolongation and hypokalemia, so she got 500 milliequivalents of potassium, some through IV, accounting for some of the IV fluid and some PO. And she put out 1,500 cc's of urine. And the content of her urine osm 546, urine sodium 22, and urine potassium 48. And we will estimate her insensible losses of 500. And this is just for the point of this exercise. So this is her total I's and O's. The question to you is, how will this treatment, meaning the potassium repletion that she got, affect her hyponatremia? Will her serum sodium stay unchanged? Will it go down? Will it come up?
What I think that it's gonna go up. It's gonna overcorrect that sodium, the serum sodium, given that and this lady is like at risk for ODS, given that she's presented with neurological symptoms, she's severely hyponatremic, and we're correcting the hyperkalemia. So we're like correcting the hyponatremia rapidly as well. So that's what I think.
So every 500 max of potassium, this is almost how many liters of fluids, right? Like this is an insane amount
some
of
of it
fluids.
was given PO. So you can get 40 milliequivalent tablets, 80 milliequivalents. But her whole IV fluid intake was 800 ml. And some of it was for the potassium. I mean, all of it was for the potassium. So you can say that she probably got 10 milliequivalents per 100 cc's, right? That's usually how we give our potassium. So she got 8 runs of IV potassium, 10 milliequivalents per 100 cc's, and she got the rest PO.
So, so I think the patient got 500 milliequivalents of potassium, and the patient poured out at 72 milliequivalents of potassium in the urine. So that's around 428 of extra potassium that's in the body now. And then we discussed that the serum sodium is sodium is NaE plus potash Ke. So I haven't done the entire calculation, especially with the amount of fluid that was given. But given that equilibrium, I think more potassium would be displaced, more sodium will be displaced from the extra cellular fluid by the potassium. So it should go down. But I haven't done the full calculation. That's my guesswork.
Okay. So obviously this person is hyponatremic and extremely hypokalemic, right? And if we think of sodium and potassium as exchangeable cations, in a way, when we replete the potassium, more sodium will come out. So actually, it's as if we're replacing sodium.
Or like more sodium is going to come out from the intercellular fluid.
More potassium is going inside, so more sodium from inside is going to come out. So if we do a just a balance, because we have everything here. I mean, this is obviously not real life, right? Real life, we won't be able to have this perfect balance situation. But given, I just want you guys to go through these calculations so you can get it in your head. The serum sodium will increase because we're giving potassium. And as I said, giving potassium is just like giving sodium. And how much, and it's because, serum sodium is equal to the exchangeable sodium plus exchangeable potassium over total body water. So in this case, we started out with serum sodium of 96, right? Times her total body water, which was 0.5 times 65 kg, which is her weight. So we started out with 3,120 total exchangeable cations. Everybody with me? This is what we started out with. So what did we give? We didn't give any sodium, right? We gave 500 milliequivalents of potassium. So the net gain, we gave 500 milliequivalents of potassium, but she lost 22 milliequivalents of sodium per liter of urine, and she put out 1.5 liters. So she lost 33 milliequivalents of sodium in her urine. Her urine also had 48 milliequivalents of potassium per liter, and she put out the same 1.5 liters of urine. So she lost 72 milliequivalents of potassium. You add those together because we're treating them as the same, right? So in each liter of urine, she lost 105 milliequivalents of cation. We gave 500. So she's netting 500 minus 105, she's netting 395. So in terms of solute balance or cation balance, she's net in 395. Now, in terms of her volume balance, we said she took in 400 PO, 800 IV, and she put out 1.5 liters of urine, and she had insensible losses of 0.5. So she's net in 1.2, and she's in 1.2 and she's out 2.0, so she's net out 0.8. So her solute gain was 3,120 plus 395, and she lost 0.8. You put those numbers together, her serum sodium went up from 96 to 111. So just by giving this woman potassium, you overly rapidly corrected her sodium.
So Dr. Chen, we just calculate the total solute gain, irrespective if it's sodium or potassium.
Yep. And that's because they're exchangeable.
When you say exchangeable,
sodium extracellular is potassium intracellular, and they're exchangeable, and they're in equilibrium. So that's why Always think of them as the same when you're dealing with hyponatremia. So when you're giving potassium, it's as if you're giving sodium. Any other questions?
I just have one question regarding the salt tabs. How comfortable you feel to send patients out on salt tab, and should their sodium be monitored frequently? And the other question, yeah.
Salt tablets is a tricky question. You know, how effective is salt tablet? It all depends on how much water you drink with the salt tablet. So how much milliequivalents of sodium in one salt tablet?
I'm not sure. I can check.
Depends how much you drink with it.
No. I mean, how many millimoles? So a gram of sodium chloride, right? How many milliequivalents? So what's the molecular weight of sodium? Back to the periodic table.
23.
23. How about chloride?
I think something around 56 or 90. I don't remember. Either it's 56 or 97. I don't remember now. But
I think it's 35.
That low chloride. Okay. Possible. I don't remember the chloride table. Yeah.
So how many milliequivalents? So it's 1,000, right? 1 gram, 1,000 milligram divided by 23 plus 35, and it's 17 milliequivalents, right? So if you take a salt tablet with 5 cc's of water, very little, that's an extremely concentrated solution, right? That's even more concentrated than 3% hypertonic saline.
Yeah.
But if you take that salt tablet and you drink 500 cc's, then it becomes very dilute. So people always get lost. I mean, it's not just the 17 milliequivalents of sodium, it's how much water you take with it. If you almost choke it down with no water, then it's very effective because it's so concentrated. But if you drink 500 cc's of water with it, then it's like very dilute.
I have the other question, like Noor, she's here with us. She was telling me one time about the urea and its role in hyponatremia. And this was my first time to learn about like that urea can be used in European countries to correct hyponatremia.
And we went through that. How does it work? Remember our problem with the hypernatremic lady? The protein supplements gave her urea, and that dragged out electrolyte-free water in the urine, and therefore she became hypernatremic.
So it is the same mechanism. Yeah.
Yes.
So that's to explain the mechanism. Yeah.
Yes. So if you give somebody urea, it's a waste product the body doesn't need. It's going to come out in the urine, and that urea is going to drag out electrolyte-free water, and therefore your serum sodium is going to go up.
Sounds good. Yeah, thank you so much.
Okay.
So urea acts as a diuretic in essence?
It's not a diuretic because it's an aquauritic. I mean, it's just pulling out water.
Yeah, water diuretic.
Water, yeah.
Dr. Shah, I have a question. In the case that we just went over, so we're seeing that there's a rapid correction of sodium, but at the same time, her potassium was like 1.6, and I think they worked out the formula to correct the potassium. So how do you sort of like weigh the two between like correcting the potassium but making sure the sodium is not corrected too rapidly?
So very complicated. You have to give free water and maybe even give DDAVP to make the kidneys hold on to the water. Yeah, so very difficult management. So in somebody like this, definitely we need to be in the ICU. We definitely need a Foley, and we definitely need blood tests, like, you know, every 2 to 3 hours. because we know, and we have to, like you said, we have to replete the potassium because of the EKG changes. So we have to do that, but we have to do it with enough water in the system to prevent the sodium from overcorrecting. So it's very complicated. And the tools to prevent the sodium, we know the sodium's going to go up, and yet we still need to replete the potassium. The tools we have are to give free water and to give DDA repeat. But the key is you have to follow very closely.